Hello, everyone. My name is Ankit Bhargav, Managing Director at Alea, and would love to welcome everyone to our discussion on trailblazing treatments and investigational approaches for platinum-resistant and refractory ovarian cancer. Today's discussion will include the latest advancements, treatment strategies, and emerging options for patients navigating the complexities of fourth-line and beyond setting, underlying mechanisms of resistance and refractoriness in ovarian cancer, and up-to-date research findings that drive treatment decisions for patients grappling with platinum-resistant and refractory ovarian cancer. Emerging clinical trials will also be discussed, such as the recently completed VERO-15 trial, as well as the ongoing on-prime trial for Olvivec, an investigational treatment by Genelux Corporation that is currently enrolling its phase 3 trial in platinum-resistant and refractory ovarian cancer, and also had their phase 2 trial, VERO-15, as an additional editorial piece in JAMA Oncology. And lastly, we'll discuss the necessary tools that will be needed to make informed decisions in the face of platinum resistance and refractory ovarian cancer. Now, I would like to introduce our panel of experts. First, we'll have Dr. Robert Holloway. He is Medical Director of Gynecological Oncology at Advent Health Cancer Institution. Dr. Holloway serves as National Principal Investigator on Prime and was Principal Investigator on VERO-15. In addition to serving as Medical Director of Gynecological Oncology Program at Advent Health, he is also the founding member of the Global Robotics Institute. Next, we have Dr. Premal Thaker. She is Director of Gynecological Oncology and Clinical Research at Washington University School of Medicine. She serves as Co-National Principal Investigator on Prime and is an accomplished clinical investigator and director of gynecological oncology clinical trials at Washington University. She is also the chair of early business development for GOG Partners. And lastly, we have Dr. Alberto Mendivil. He is co-director of gynecological oncology at Hoag Memorial Hospital Presbyterian. Dr. Mendivil serves as principal investigator on Prime. He's also the co-director of the Hoag Gynecological Oncology and Pelvic Complex Surgery. Dr. Mendivil also leads the gynecological cancer clinical trials at Hoag Family Cancer Institute. And with that, let's jump right in. First of all, I'd love to thank all of our speakers for being here today and discussing this very important topic. So just to get us jumping right into it, would love to kind of really see what your thoughts right now are the patient needs in the platinum-resistant and refractory ovarian space, and where do the current gaps exist?
Well, thank you for having me, and that's a great question. Really, when you get platinum-resistant ovarian cancer, it's sort of very disheartening for both the patient and the provider, since we really don't have great treatments for patients at this time. So this is really the critical need in the ovarian cancer patient journey. So platinum-resistant is defined as having a recurrence that's less than 6 months from the last platinum dose, or platinum refractory is when it grows either on the platinum or less than 3 months from their last platinum. And this is an area that needs intense research because of the fact that our differential progression-free survival for most patients is about 3.5 months. And right now we're just using weekly chemotherapies, or we're trying to use new novel oral agents. But for patients, they want to have more durable responses. So we're really in a critical need to find out different methodologies to get active drugs to these patients.
Those are great points. I'd also like to thank you for having us here today. It's really a pleasure. I want to make a point about one of the unique aspects. There are many unique aspects of viral oncolytic therapy, but one of the unique aspects to understand this is a immunotherapy category treatment with a biologic that is really for all comers. So many of our new developments, which are worthy of investigation, are directed at specific targets on cells. This is a all-comers immunotherapy. The target is a cancer cell that is dividing. This oncolytic virus has a knockout gene for thymidine synthetase so that it seeks an environment that's rich in thymidine, and that's a rapidly growing tumor. So it selects these cells, replicates, kills the cell, releasing oncoprotein, which is then recognized by the immune system. So we create immune memory for the specific cancer with this treatment, And then we go on with cytotoxic therapy to keep this a hot tumor, and we'll explain that a little bit more detail later.
No, I think that makes a lot of sense. And I think one thing it's great to discuss is right now, I feel like a lot of the ongoing trials are really for second and third line patients. Maybe this is jumping the gun a little bit, but what are even the thoughts right now of treating patients in fourth line or beyond therapy?
Well, again, thank you so much for having us, for the opportunity to discuss what we're doing. When we have patients with ovarian cancer, we really want to try to give them the most effective drugs as soon as possible, or as early as possible. There are many drugs that are being used now, very exciting new drugs, such as drug antibody conjugates, using treatments that have been shown to have some benefit. But when you get beyond the third or fourth or fifth line of therapy, the effectiveness and the duration of response really diminishes. And so we really need something more for patients in that space. And really that's where a treatment like this comes. Once we get beyond a certain level of treatment and certain lines of therapy, patients are really seeking something new, and we want to be able to provide something different and new for patients. The real question is, well, if we can reuse a drug that's known to be the most effective in that particular treatment initially, which is platinum-based chemotherapy, why not come back and give that particular drug? And up until now, really don't have a lot of good evidence that supports the reuse or the re-challenge of platinum patients that have previously failed that drug. And this is a really exciting time, a really exciting concept and treatment paradigm to consider going forward.
No, I think that these patients need quite a bit, right? And unfortunately, there isn't a lot of options. I think Dr. Holloway, maybe you could even go in a little further of kind of where the biases have been, even with going back to earlier line therapies.
Well, as Dr. Mendivil stated, once you become platinum resistant or refractory, by tradition, patients usually do not return to a platinum based therapy. So we know that ovarian cancers, epithelial ovarian cancers, have homologous repair deficiencies, which make platinum-based therapies particularly useful. Unfortunately, over time, these tumors develop resistance patterns and they're not responsive. So one of the other unique aspects of this viral chemoimmunotherapy approach is that the oncolytic virus, through several mechanisms, modifies the local, what we call the microimmune environment, to not only make it immunogenic and therefore create response in a platinum-resistant patient, it actually reverses some of the resistance mechanisms in the microimmune environment through glutathione transport mechanisms and other metabolic pathways, which have been described in translational research. So we're essentially energizing the immune system to attack the cancer, as well as reverse some of the platinum resistance mechanisms in the local environment to achieve more cell death with platinum-based therapy. And that has helped us, we think, to achieve the results that we've seen in our phase 2 trial.
No, I think the changing the tumor microenvironment and the role it could potentially play in the resensitization is extremely important. I think it may even be just jumping into really more of the clinical approach, as well as what it means for patients, is how might resensitization to platinum impact the actual overall treatment paradigm for PROC patients? This may be a great question for you, Dr. Mendivil, just because, with the recent discussion you even had on the JAMA Oncology podcast.
That was me. Yeah. Okay. Well, as I mentioned, the whole concept of resensitization of platinum is a bit obtuse in the scientific literature, and we really haven't had any evidence in the literature that we can reverse platinum resistance. That once you're platinum resistant, you are platinum resistant. We've had some clinical trials that have tried to extend what we call the platinum-free interval over periods of time to show that you could retreat with platinum and get a better response, and those trials have been negative. So the discovery, with this treatment paradigm, is that when we treated patients with monotherapy virus and we saw responses, many of these patients maintained good performance status. And naturally, when we were done with our phase 1 trial testing the virus, they went back on to cytotoxic therapy. And because they had such a good performance status, many of them got platinum doublet therapy with bevacizumab. And we just recognized that many of these patients got incredible responses, clinical responses, shrinkage of tumor on platinum-based therapy. And that's why we went on to the phase 2 trial and demonstrated those responses and survivals. And we're now into a phase 3 concept for proof of principle to show that viral immunochemotherapy can result in platinum responses that have not been seen in previous trials.
It's such a new concept because some of these patients just have no business or had no business in terms of what we saw in the phase 2 trial to have a significant response to re-challenge with platinum-based chemotherapy, and it was so exciting to be able to provide these treatments for patients that were looking at potentially doing no further treatment or exhausting all existing and current therapies at the time. And so by deciding to bring back a therapy that at one time was effective for the patient, that is generally well tolerated for the patient, to be able to then bring back some of those drugs that they used initially, at least at the beginning of their treatment, and given that they are in such good shape from a physical standpoint, it is exciting to be able to provide this repriming of the patient's immune microenvironment to be able to have a treatment that can certainly be effective once again.
No, I think it's just amazing. And I think one thing that we should touch on here in this discussion is even specifically, I think this was mentioned in the podcast, was really the effect on refractory patients and how difficult this has been and the overall response. So I think it may be great to just really quick touch on what we saw with these refractory patients, what may have been expected, and where the excitement was drawn from this trial.
I think that was another eye-opening part of the Viral 15 phase 2 trial, that we had about half of the patients were platinum refractory. Some were primary refractory from the first treatment. The majority were secondary refractory, meaning that they grew tumor. We actually used a 1-month definition, so they were growing tumor within 1 month of their treatment or on treatment. And we saw really no difference in the response rate. The response for the entire group was about 55%, and the progression-free survival was in the range of 11 months, and it really wasn't different for the platinum refractory or platinum-resistant category, which again has not really been recognized in any trial literature that I'm aware of. In fact, most clinical trials will not enroll or accept a platinum refractory patient because they have such a poor prognosis, they ruin the trial. So recognizing that we had a treatment concept that was apparently reversing platinum resistance through a variety of mechanisms and giving response, it was eye-opening that we really had something that potentially could become a treatment for patients who have had multiple lines of therapy and were platinum resistant. And as it goes, we went through a phase 2 trial. Now we're into the on-prime phase 3 trial, which is a GOG Partners sponsored trial in multiple institutions. It has a 2-to-1 randomization scheme, and we're in the entry phase of that trial to get a proof of principle that this is an active therapy.
No, I think it's very exciting data that came out with Vero 15. Obviously, the editorial piece was fantastic. And I think, early part of my career was spent in oncology, and it was very eye-opening just from the patient aspect, how exciting this really could be. I'm sure, Dr. Thaker, you actually had probably a lot of excitement also seeing the results. And, now with on-prime, would love to hear a little bit more also your thoughts on the patients and on the on-prime trial itself.
Perfect. I agree with you with the excitement about this because remember, it's not only platinum refractory, but it was also patients who had had up to even 9 lines of prior therapy. So, the median patient sort of amounts of chemo they had was 4, which are not usually heard of on trials. So, this is a great option, as we mentioned, because we're allowing patients really an all-comer population, which is key because I think we've all faced that patients get very disappointed if they don't have the target. And on top of it, we're dealing in that patient population that has really limited options. So on-prime is a great option for patients. And so it is a trial that will enroll approximately 185 patients. It's 2-to-1 randomization in favor of getting the viral therapy along with the chemotherapy, which I think patients love because they don't want to be in the control arm. They really would like to get the active agent. So I think that's also another great novel part. And it's really a 2-day therapy of the infusion of the virus into the abdomen once you have a port placed, followed by chemotherapy of platinum and a doublet of another sort with bevacizumab. So I think it's a great option because it gives patients, chemotherapy that they've heard of and responded to because, patients always ask that question, why can't I go back to platinum? And now we're hopefully resensitizing them. So I think it's a very attractive model for patients. And we really encourage people to open the trial and also find a location close by if they cannot, because we really want a lot of patients to have the opportunity to participate and hopefully further the science so we can continue on our great, quote, wins so far.
One of the things that's interesting about the trial is for my colleagues, it really challenges our mindset and our kind of treatment paradigms for patients in the sense that they, once you fail a regimen, that you go for something different. You want a different mechanism of action. You want to see a different target or at least go after a different target. And while there are several new targeted therapies, antibody drug conjugates that are being developed, angiogenesis inhibitors, the opportunity to be able to go back to probably one of the most effective type of chemotherapy drugs that we have. One of our colleagues once joked that if I'm on a deserted island, if I have one drug to take with me, I'm going to take carboplatin because it pretty much works for everything. And how amazing would it be to be able to give a patient an agent that would all of a sudden allow us to retreat with a drug that's very effective, that we all know how to give pretty easily. We know that we can predict the side effects, and patients generally do well on combination therapy with platinum-based chemotherapy.
No, absolutely. I mean, this is a large milestone potentially for patients. And I think it's a forgotten population, this 4th, 5th line, while there's been a lot of focus on these 2nd and 3rd lines and some of the other trials, just given how sick these patients are. But with looking at it as a whole, I mean, we're seeing where Ovivec may have a play in the tumor microenvironment, resensitization of platinum and the treatment paradigm. But really looking even earlier on, what is the chance for first line down the road, given the results seen?
I think that's the ultimate goal and the ultimate hope. We have to start with the need right now is platinum resistance because these patients are using a experimental therapy and they have very limited options, and that's typically where you introduce new drug development. Once you see a signal that you have activity, naturally we want to bring that further forward. And I can imagine that with this chemo-immuno concept, there could be a benefit to engaging the immune system earlier on. We know that about 20% of patients with epithelial ovarian cancer have a brisk immune response with their chemotherapy. From years of study looking at tumor-infiltrating lymphocytes. And, we know that we roughly cure 20 to 25% of patients out the gate with carboplatin, Taxol, Bev, and they don't relapse. Well, why not 100%? What's going on with the other 75%? We don't exactly know the reasons for all these other patients, but it's got something to do with the interaction of their immune system, I suspect. And if we could energize the T cells and make them hot tumors, so to speak, with TILs, infiltrating lymphocytes earlier in their disease course, we potentially could make a bigger impact on overall survival in ovarian cancer. I would imagine, we could next bring this up into platinum-sensitive recurrent disease settings, or even in interval cytoreductive surgery settings where I could envision we could give the virus after an interval cytoreduction, try to wipe out those remaining stem cells, with oncolytic virus and energize the immune system. There's a lot of things we could do with this. We got to get over the first hump first.
That's right.
You get a proof of principle done in a phase 3 trial.
One thing at a time.
Yeah. One thing at a time. So no, with that, I really, really think that there is a lot going on. And I really want to thank you guys for being kind of at the forefront of this therapy as both physicians, investigators, and also lastly as panel guests here today. So once again, thank you so much for giving us so much more insight into platinum-resistant refractory ovarian cancer, the upcoming trial, as well as really where all of this could go and the meaning to patients.
I appreciate the opportunity, and I think we all agree that it's the patients and their families that are really we're truly grateful to and thankful for their participation. Without them, we certainly this wouldn't be possible. And for them, we're trying to come up with a better way for these patients to have a better quality of life and better quality of life and quantity of life.
Yes. Yes.
Absolutely
No.
great.
Thank you
Thank
so
you
much.
very much.
Thank you.
Thank you.